Everyone, and welcome to today's webinar. Our speaker today is Christopher Pratt, Senior Consultant with Cordemanch and Associates. At this time, all lines have been placed on mute to prevent any background noise. We will have a question and answer period throughout the presentation. Type your question using the question prompt. They'll be answered in the order they were received. Please identify the name of your organization at the beginning of your entry. As a reminder, this webinar is being recorded and will be available in the CIHQ YouTube library within a few days. It's now my pleasure to turn the webinar over to our presenter, Chris Pratt. Chris, you have the floor.
Outstanding. So happy day, everybody. My name is Chris Pratt. I am a senior consultant with Cordemanch and Associates. I'm a registered nurse by trade, about 39 years. I appreciate CIHQ for having us here to talk to you guys today. We're going to be going over some things regarding rounding for quality and patient safety. So we're going to talk a little bit about what it means to round, the key elements of successful rounding. We're going to provide some examples of rounding techniques, some things that we've seen that work really well. And we'll also talk to you about some pitfalls and some challenges that different organizations have in terms of implementing a successful rounding process. And we're also going to describe how you can leverage rounding in your performance improvement initiatives. So we'll briefly touch on that. We do have a lot of information to go through today, and it's kind of difficult to cram everything, all that's rounding in an hour, but I think we're going to hit some of the highlights, and I'll share with you all some of the things that we see when we go out and we're doing mock surveys and we're doing our own rounding as we go out and look at regulatory compliance for different organizations. I will stop a couple of times during our presentation to see if there are any questions, but please go ahead and reach out as we're going through, and we'll take questions at the end. So looking forward to talking with you all today. I hope you all enjoy this, and we'll see what questions you have at the end. So let's get into our presentation. So it doesn't take much effort to really review Becker's or other healthcare publications to see where the lack of oversight results in significant consequences to healthcare organizations. Top leaders in healthcare organizations absolutely have to set the tone for their subordinates in terms of engagement with their staff, which really involves oversight for safety and quality. And you can see the headlines here that there are a number of organizations out there that have significant issues when it comes to patient safety. Many organizations include engagement as part of leadership performance evaluations. However, these leaders must have guidance, training, and coaching to ensure they understand the expectation of what that engagement is and actually how to do it effectively. We're starting to see those of us as healthcare leaders who are more seasoned. We're not older. We're just well seasoned, but we're starting to retire or leave the profession. And there seems to be a gap with these new leaders that are coming in that it's a newer generation. They may not, they're from the digital age. They're used to texting and I mean, even my own kids who are older, the engagement face to face is just something that just doesn't happen with that generation. And I think that's left a gap in that type of engagement that you expect to see when you're providing oversight with patient safety. During our mock surveys that we conduct, we're seeing a number of organizations that really stopped rounding due to the pandemic, and that's been kind of long gone. But again, they've not stood these back up again. We're seeing increasing conflicts in work demands. People are wearing multiple hats and have different roles that they're trying to fulfill. The staffing issues, the issues regarding getting leaders in. And then again, we talked about the experience and just being able to manage around and what to look for and how to engage with people. And as a result, we've seen a lot of opportunities as we go out and do these surveys that I feel could be tied directly back to the lack of leadership oversight. People are just not going out and looking at processes, and organizations have to get their leaders out at all tiers, back on the floors, back in the units, back in these different work centers, and round to support patient safety. Because ultimately your facility could be the next headline in Becker's, and obviously we don't want that. Now, I love Yogi Berra. I come from a family that loved baseball, and I love yogiisms. And I was thinking about which one would apply to rounding, and I think this one hits it right on the head. Yogi Berra is right. You can observe a lot by watching. And if leaders and managers were just relegated to reviewing written reports or spreadsheets to ascertain if their unit or organization was delivering safe and efficient care, I think the prevalence of patient harm would skyrocket. Nothing can beat management by walking around, observing processes in place, engaging with staff members, determining what your culture safety is like, what things are going on out there that can contribute to patient safety. What are we doing right? Is there stuff that we need to grow and expand? And for those of you that are really into Lean Six Sigma, and I'm a Dr. Deming Lemming, as they used to call them, we're really talking about doing the Gemba walk. And there's a thing that, for those of you that don't know, it's called the Gemba walk, and getting to the Gemba. And it's something that Toyota put in place to look at their processes and to make certain that things were safe and people were being efficient. And in the Japanese term, Gemba really refers to getting to the place where things happen. And this presentation is going to really review different aspects of rounding for quality and safety, provide some key considerations at each, and recommend on how you can leverage this rounding to help ensure that your patients are safe and your staff members are supported and engaged in the delivery of care. So first, we want to talk a little bit about the essential elements of successful rounding, really what makes a good rounding program at an organization. And with each section, I've actually shared some of the things that I found when I've been out rounding. And, you know, I believe in digging, getting in and looking in drawers. What do we have hidden behind door number one? I found this beauty right here, the one that's in the center of this image. This actually is an old sphygmomanometer. It's in a case that opens up, and I found it in a drawer in this one location, medication room. They said, oh, we never go in that drawer. And when we opened it up, I found it, all of the black rubber was dry rotted. And what's in the center there is this beautiful glass container of mercury. And you never know what you're going to find when you go into these places. So rounding is important, that you do it thoroughly, and you're looking for opportunities out there that could potentially pose a risk. Before we jump into the essential elements, I think it's important to talk a little bit about where rounding fits in terms of the safety culture ladder. And I found this infograph a couple of months ago, and I had an older version that I use when I talk about high reliability. And I think this one really speaks a lot better to it. Solid rounding fits into the safety culture of an organization as it helps move organizations from a more proactive to a more proactive and generative state, that's at the top, from being a pathological or reactive state. And in those places, that's where organizations at the lower end are thinking, well, you know, who cares as long as we don't get caught? Well, we're really not looking for trouble. If we don't look for it, it doesn't exist. You know, and we need to get people up to that proactive and generative state where rounding is substantial. It's not just walking around and shaking heads. It's about verifying processes are in place, that those processes are working, and identifying those that are not. Organizations must be wary of a term called risk creep, and that's where deviations from acceptable practice become the norm. Staff are taking shortcuts that increase risk. You know, they're not conducting the hand hygiene before they do a process, or they are, you know, a piece of equipment broke or something else happened, and they're changing that process. And these small deviations eventually become the norm. And you're not going to see that in any type of spreadsheet or any type of dashboard on quality until it actually becomes patient harm. It becomes a real event. Rounding has to dig deep in looking at processes and ensuring that we're aligned with safe practice, because the most dangerous deviation is the one that doesn't look like one. And that's where it comes down, where rounding is imperative, that you get out there and look at these things and see these things. We've identified 3 elements that we feel are the core for an effective rounding program, and those include leadership, systems, and training. Now, individually, they can support good practice, but they also must complement each other to ensure that rounding works for you. And we're going to talk about each one of them here. And as we're doing that, think about your own leadership system, your own training system, your own system that supports rounding to see how does it fit in terms of supporting an overall good framework for your rounding program. So first of all, let's talk a little bit about leadership. The expectations of leadership by regulatory organizations has been focused on ensuring that they are responsible for the delivery of safe and efficient care. Although there's been requirements and standards that speak to this, it's only been seemingly the most recent past that we're seeing increasing numbers of citations being placed on leaders during survey findings. You can go back to one of the first slides I showed you, all those headlines. They're going after the leaders because of a lack of oversight. Added this, the expectations, there's a robust quality and performance improvement program in place that identifies opportunities and addresses them. And it's clear to see that rounding is a critical element that leaders must support, ensuring that they're providing safe care. They have to ensure the safe operation of their organization. And one of the means of accomplishing this is to convey to their staff the importance of safety and quality. Rounding provides an opportunity to evaluate staff regarding their adherence to those practices set by leadership. It also demonstrates to your staff members that, this is important to the organization. When you see your CEO or you see your directors going out and looking at sterile instrument processing, it conveys that message that this is important enough to get these people to come into my workspace and look at that and ask the real specific questions in terms of our process on the sterile instrument processing. It sends a strong message. The use of targeted rounding specific to specific issues regarding safety and quality lets the staff know that these issues are important and provides them the experience of having leaders question their actions and their roles in delivery of safe and efficient care. It prepares them for survey teams who will be asking some of those very same questions. So there's nothing better than immersive simulation and immersive training. And by doing rounding, it gets people to experience that when they have somebody come in and ask them those questions. Now, leaders drive a successful rounding program where they can kill it even before it leaves the launch pad. There must be a top-down commitment by leaders for rounding, that managers and supervisors are expected to round on their workspaces and with its practices. Now, I was active duty Navy for about 30 years as a Navy nurse, and the last place I was stationed at was Naval Medical Center, San Diego, and our commanding officer was a surgeon by the name of Captain Jose Acosta. Absolutely wonderful physician, brilliant surgeon, and an absolutely fantastic leader. And he really set the example, I feel, for rounding. And his biggest bugaboo was supply rooms. So he lived on base, but he would always show up about 5:30 in the morning, and he would go find the night corpsman for a particular unit and have them take me around to your supply rooms. Let me take a look and see how you've got those organized. And that was the big thing that he would look at. And he was going to the most junior person and having them go through their process of ensuring that those storerooms were kept clean and stocked, and if they had everything that they needed. So he really set an example for that. He also supported a blitz type rounding model that we did, and IHI has that. I think they call it the walk rounds model, and it's been out for a while, where we would go out, HR would go, we'd have somebody from training, somebody from quality, regulatory, facilities, nursing, and other individuals training. They would go and we would go to specific units, and we would kind of do an overall review of those different elements, and we would rotate through the facility. He really helped support that as a way to kind of really dig in and look as a supportive group what opportunities exist and what can we do to help mitigate those. Leaders ensure transparency of rounding. The findings and opportunities ensure that they're identified are addressed, and that's communicated back to the staff, because when staff don't get that, they just feel that, well, what's the need of them coming here, and we address issues or bring things up, and none of that stuff is spoken about or nothing's addressed. Leaders set the expectations that that these opportunities are addressed by their subordinates, by their facilities folks, and it builds that trust with staff. Most importantly, rounding is non-punitive. We address the contributing factors for the finding and not fault the individual unless there's a blatant deviation from practice and policy. And we dig in to understand why didn't we follow that practice? Why did we follow that policy? Is there something wrong with our practice or policy? So we dig into that and keep the patient as the focus. Leaders openly communicate concerns with staff, and they praise them as well, obviously. And they solicit their input and concerns regarding patients and and staff safety, excuse me. This all contributes to creating a culture of safety, focused on the patient and always looking at one's own practice to ensure that we can do it better and we can do it safer. And that's important. Unfortunately, results of regulatory surveys often identify gaps in effective leadership. Again, the headlines that we saw. Surveyors often find significant issues with infection control processes, for example, that they found that leadership is disengaged, uncertain as to the requirements, or just don't provide oversight for their organization. For example, we go out and I was at a place in Texas this past week, and their endoscopy processes, they were not following anything in terms of leak testing, ensuring they had proper ratios of disinfectant to the water. They weren't measuring volumes. They weren't inspecting the endoscopes. When we asked them about how often are you cleaning the endoscopes storage cabinets, and we got a variety of different answers, so nothing standardized. And we asked, well, have you guys been rounding on these places? And leadership indicated they indeed had not been doing that. So that's the kind of common things that when you see those, they roll up into those significant findings by survey team, or even worse, when we actually have events where we're infecting patients, we're not cleaning our endoscopes or other things like that effectively, and we end up with patients getting infections, and that's bad. And it goes back to where we're not actually rounding on these places to ensure we're having safe practices. Excuse me. The concepts of quality and safety often are not kept at the forefront of leaderships as they struggle to understand their role or deal with staffing and other challenges. When staff experience disengaged leaders, or they have concerns about the competence of their leadership, this can result in diminished confidence in the organization and supporting a culture of safety. Staff can be disenfranchised and frustrated with a lack of leadership because they don't see them out rounding on practices and processes. And this contributes to the increased turnover of staff as well as the increase in patient harm events. If they don't feel it's important to the leadership, that they're not vested in doing safe patient care. Unfortunately, this can take the form of a vicious cycle that brings an organization down and subjects it to scrutiny by regulatory agencies and the customers that they serve. It's imperative more than ever that leadership is engaged and rounding to support their staff and ensure safe patient care. Now, some leadership tips. If you're setting up your rounding program, it's important to get that leadership buy-in. Ensure that they understand where they fit into the entire rounding model. And unfortunately, sometimes you have to you can either use a carrot or you can use a stick. Now, the stick model is you show them that slide with all those headlines on there and say, look, it's important that you're out there, because if you're not out there looking at this stuff and addressing some of these issues that we identify, we're going to end up on the front page of our local paper and in the news, and it's something we don't want to do. Get them engaged in the process of designing your rounding or reviewing your rounding processes. Ask them what do they want to get out of rounding and how they value that. Is there something specific they want to see? You want to show the return on that investment of leaders getting out there. And we'll talk at the very end. We have like a slide that talks about how do you measure success for rounding. And some of those things can be things like your culture safety survey results, the engagement of your leaders showing up, morale of your staff, turnover rates, things like that. When your leaders are out there doing that rounding. Talk to them about maintaining transparency when things are identified as a trend or a significant issue. that we address those things and we send that out, and staff can see that, hey, if something's a problem and it's identified, it's addressed by leaders. And it really comes back to delivering on the goods of being a good leader. Let's talk a little bit about systems. So we got leadership. Systems is the second part. Effective rounding requires a structure to ensure consistency in practice and a framework from which to operate. Without structure, organizations will struggle to hardwire rounding. This includes establishing processes for rounding like planning, scheduling, team selection, your observation tools that you're going to use, the checklists that you're going to use, what type of references, instructions for use for specific pieces of equipment, what type of job aids we're going to look at, your analysis process. So how do we take this data and really tear it apart and look at it? And what did we learn from it? Are we seeing anything? How do we report our findings out? And how do we share the data in providing standardization and a set expectation on how the organization will conduct rounding? So structure is important. Well-established systems will help ensure that rounding processes will be sustained over time, and they're not relying solely on a single individual driving that. It's how we do business in this organization consistently every time. Consistent rounding practice supports leader and staff expectations for rounding. It ensures the identification of opportunities, whereas informal or undefined processes may not be consistent. A structure that establishes analysis and risk mitigation practices will help the organization focus on risk identification. We're looking for those shortcuts and deviations from acceptable practice that create that risk creep that I was talking about earlier. Systems designed with elements of safety culture keep the patient at the center of the rounding process and encourages transparency by both staff and leaders and sharing of concerns and ideas. It's not about shame and blame. When we find something, what happened? Why did we think, why are we seeing that deviation? And is there a reason that supports that deviation? It could be anything. It's about setting staff and leaders up for success while keeping the patient at the center of focus. Now, with a lack of structure, and this is one of my most favorite cartoons from Gary Larson, The Far Side, the Boneless Chicken Ranch. Hopefully your rounding program doesn't look like that, but with a lack of structure, you get inconsistencies, you get unfinished work, a lack of follow through with addressing identified opportunities. And I've seen this a few times when we've been out. Oh, have we seen that? Well, we identified that last year. Okay, where did we go with that? Well, we kind of looked at it and then we just didn't pick it up. We didn't keep going with it. So there was no follow through for that. Asking organizations about trended findings. When we see the same issue regarding initial decontamination of soiled instruments in all of their units, that's a trend, and we're seeing that when we're going out, but they're not identifying that and an understanding that that's a vulnerability as an organization that they need to face. Staff and leaders will lose confidence in the rounding process, which will eventually fold up with a lack of commitment. And this all leads back to poor patient outcomes. Consistency and standardization is key, and that's how a system can support that. Our recommendation, start slow. If you're just getting your rounding program off, or you're looking at reinvigorating it or restructuring it, start slow. Set up your processes, set up your rounding, your analytics process, how that ties into performance improvement. Build your structure before you actually execute that. So as you're starting to roll with that, you can make modifications if you need to, or your structure and system may be just fine to address the rounding data that you have. If you're looking for, well, what do I look for, or how do I look at it? Look at evidence-based practice, EVP. There are plenty of people out there that have periodicals, different type of publications out there on how they've been doing rounding. And you could take that and modify it or use it as whole. Look at your processes, soup to nuts. That's everything from when we do the initial decontamination of a particular device all the way through to looking at maintenance of our sterilizers, or how do we make certain that the testing strips have their quality controls in place? Do we have quality controls in place for that? Or we follow instructions for use? So look at whole things when you're doing your rounding, and consider the different parts of the processes that you guys work. Use tools and checklists. That helps standardize your approach, helps standardize your process. Ensure that you have effective analytics processes in place. When we get this data, how are we going to take this stuff apart? Do we have people skilled that can help us look at this data? And then always make certain that you're able to modify your process as you need to. If we identify we're missing this, or we need to work on this, modify your process, make those changes, and see how those things go. So you're doing performance improvement on your rounding process. Last is training. This is the what, the why, and the how. So how do we, what are we looking at? Why are we looking at it? Or how do we do this? Or how do we fix this? It educates teams on expectations for how rounding will be conducted. And it goes back to structure. All know how rounding will be conducted from start to finish. That's our goal. Most important is to train your leaders in how to round, what the regulations state, and be familiar with interpretive guidelines on how to apply the regulations. We find many locations that are not performing robust rounding as a result of not knowing what to look for. And specific, I'll go back to the endoscope thing that I found last week in Texas. When I asked the team there, leaders, well, how do you guys know what to look for with this? And they were really not sure. And I talked to them about the instructions for use. We actually pulled it out, and I walked them through saying, as you follow through, here's the things you need to be looking for. Are we doing leak testing? They were not doing leak testing on their scope. Make sure you're cleaning at the point of use. They were not doing that. I said, so it's right there on what you need to look at. And also get people to look at the CMS interpretive guidelines. I mean, that's your playbook right there for a surveyor. And that's a great way to teach the people on what a surveyor is going to be looking at. And how do when I do these record reviews, or I'm looking for this, what are some of the considerations that I need to do? And that's a great way, I think, to help educate people on what kind of things and how are you going to look at something to determine if you're compliant. Training provides these stakeholders with lessons learned, opportunities found, best practices to copy. Training helps change good rounding practice to even better rounding practice. I learn from every consultant I ever go on survey with, because they will look at things maybe a little bit different, or they heard about another time when they surveyed a different location, they found something unique. So as you're building your rounding program, make certain that you're sharing those type of things between your people that actually do your rounding. Hey, this has been a big thing that CIHQ's been seeing, or CMS has put something out regarding this type of thing that they've been seeing out there regarding dialysis. And we need to apply that to see, is it happening with us? As you share that information with your individuals that are rounding, you're building on that knowledge capital as an organization to make you all much better when it comes to rounding, and share those lessons learned and those findings that you have. Pushing rounding down through the ranks is important. Training on rounding builds your managers as leaders to help them support the spread of the culture of safety, what to look for, what's important. Training empowers your staff as they can learn how to be compliant with regulations and policy, and if needed, adjust their own performance. I think it also helps teach them the why. Well, why am I doing it this way? How does that apply? And I think that's your new workforce is important on teaching them the whys. They want to know why they're doing this. And when you've got good training that helps support that, I think that's going to go a long way. Now, shifting from reactive to proactive on patient safety issues is the key. We talked about that ladder before. Rounding and not learning from the process or sharing what you learned is self-defeating and sabotages the reason why you round in the first place. Organizations should learn from both the good and the not so good practices. As learning becomes more embedded in rounding, organizations and staff will start looking at themselves as a learning organization, where it shifts from, again, being reactive to proactive. In today's fast-paced healthcare landscape, the ability to rapidly learn and change is often the only sustainable competitive advantage when you look at competing organizations and challenges from regulatory agencies. It promotes agility, boosts staff retention, because staff highly value upskilling, and it turns organization challenges into strategic opportunities for growth and safety. We become more agile, able to innovate as these new issues emerge. And if we have new threats such as COVID come across, we've built ourselves up as a more proactive and generative organization, if you go back to that ladder. So when these new things do show up, we're better able to address those and flex to address the new threat, just from rounding and learning and understanding ourselves as an organization. Now, when you have a low emphasis on training, staff become less engaged. You start seeing something called learning tyranny start to emerge. That's rigid learning. We're not adaptable to new innovation, or a lack of critical thinking. We kind of develop this on our own, and this is what we're going to do. Learning silos develop with those who embrace learning to others who don't, and certain parts of your organization may see themselves as being the expert for it, when indeed, if there's no oversight or coverage on learning, how do we know that they're actually teaching the right thing? This all contributes to poor compliance and safety risks. And we always ask about people debriefing after events and what did they learn from that? And many organizations either do not do them, or they don't share their identified issues. And you can see those are the dangerous quotes we hear a lot of times when we go out and round. Well, sometimes I do it like this. This is how I do it. We've always done it this way. Well, the surveyor never said anything about that, or they never looked at that. So I think those are things as you're going out rounding to look for, to key into where we may have an issue. My biggest thing recently has been usually this is what I do. So having that conversation with staff goes, well, when don't you do that? Well, I always do it. Well, then instead of saying usually, say our process is, or we always do. So those are some things you pick up as you're going out and rounding. Some training tips: define and educate to the compliance standards. What are you looking at? To the CMS standards, the CHQ standards. Educate people as to what are expectations or performance. Teach to understanding of the why. I mentioned that earlier. The newest generation really wants to know the why. That helps solidify those requirements in their head and hopefully to their performance. Look for lessons learned and share them. Hey, when I was out rounding in NICU, I noticed this. Hey, okay, maybe we need to look at that somewhere else, because it could exist there as well. And develop your leaders and staff on compliance standards. Embed that in them. Get them to understand that. So when we talk about the conditions of participation, you don't get that deer in the headlights look. They're able to say, well, yeah, I know what that is, and it talks about this. So again, it's about helping grow and develop your staff and your leaders to understand the regulations regarding the patient safety. Because I can tell you as a nurse, we really never got that. We just knew that the joint, ARSA's Joint Commission, they're going to show up, or these people are going to show up, and well, what are they looking at? Well, we really didn't know. Any questions so far?
Well, Chris, I've got one question. So what degree of importance do you put on staff interaction during survey?
Well, that's a good question. We're actually going to be bringing that up here in the next couple of slides. When we're going to be talking about rounding techniques in this section, and there's some basic frameworks that we think you can put your rounding processes in. Interaction with staff is absolutely imperative. Now, there may be some times when you don't have that interaction. Let's say we're in facilities and we're going to be looking for IT lines resting on sprinkler feed piping. You may not have a lot of interaction with somebody in the overhead like that. But if I'm going out and looking at processes and things like that, you've got to make certain you have that interaction with staff. You want to hear it from the person who's actually doing the process, not the leader. I mean, you can talk to the leader off to the side about what their role is in it, but ultimately you really have to talk to that person who is turning that wrench, you're not really doing turning wrenches, but who's actually doing that process, who's doing that initial decontamination. How are they doing that? Describe to me how you clean and disinfect this particular item. What do you use? How do you use it? And that only can come from that individual, because you will learn a lot when you talk to people about, are we seeing shortcuts? Are we seeing those deviations from accepted practice to when it's actually become the norm? And that's the dangerous part about risk creep, that you won't know it until you actually talk to people. And that's the imperative part. So good question. So let's jump into rounding techniques. So some key tips initially, you want to utilize rounding to identify vulnerabilities and opportunities. What's going on out there? Where are our greatest risks? Use those scripts and checklists to standardize your process and promote consistency. Now, there's some that you'll go out and I don't want to call you freelance, but you'll just go out and let me just walk around and see what's going on. If you're just going out and talking to people about a key couple of things, you may not need to have those scripts and checklists. But as you're starting to build on your rounding program, those scripts and checklists help develop at that base for you to branch off from. And I've been with Quartermatch and Associates coming up on 8 years, and I used to take scripts and checklists out with me a lot just to give me a reference. But the more you do it, the more you're actually able to remember that stuff, but also adding additional things to it. So standards do change. Make certain you update those. Make sure you analyze your findings for trends. And I think that's where a lot of people struggle. They're doing a lot of pockets of rounding, but they're not bringing their data together in a way to say, are we seeing some type of trend here from these different locations for this particular process? Engage with your staff to develop the culture safety within your organization. And we're going to talk about that here shortly with some of the questions you want to ask. Again, that engagement with staff is important, but the culture safety really, as you're doing your rounding, helps teach them that and what we're trying to do. Shine the light on what's right. You want to recognize where good things are happening, and those things you might want to note those, because it might be something that we can move into another place. Make certain that when you're recognizing good practice, it's got to be authentic and meaningful. Otherwise, people will see right through it and recognize that you guys are just giving them lip service. Look at patient satisfaction and peer recognition and addressing those. Acknowledge all team members who support that success. Everybody from the individual who's cleaning your operating room all the way to the person who's supplying your operating room. So it all takes a team. So look at all of that and acknowledge where you're seeing good things happen. It's easy to succeed if you know what success looks like. And I found that quote some time ago, and that's absolutely right. I think we're quick to go out to round to find deficiencies, but we're slow to identify where we have best practices as a way to say, can we export this to the other locations? Because you've got some really smart folks out there doing some really great stuff, and we need to be able to capitalize on that. Emphasize the importance of well-being. Burnout is rife in healthcare. World Health said something that affects like 15.6% of all nurses, according to one study. I think that's probably a lot higher, and over half of all U.S. physicians. And I think that it hits the disengaged the hardest. 41% of all disengaged nurses show signs of burnout, and we've got to get out there and find out how our staff are doing. Having a resilient staff prepares you for the next challenge that's coming up. And if we're not addressing that, then our folks are in the hole when it comes to being on their full game to be able to prepare for undetermined and unseen risks that may come next. Again, think about COVID. Now, talking about rounding techniques, we we look at, there are two types that we kind of looking at. There's safety rounding and quality rounding, and they have two different meanings which require different approaches, skills, training, competencies, and expertise. For quality rounding, we're looking at the degree of excellence measured against an established benchmark. So we're rounding for quality. We're looking at your falls program. We're looking at, so what's our falls rate doing and how are we doing with falls? For safety rounding, we're observing work areas and processes for the absence of harm, danger, or risk. Sorry. Here we go. So under these two different types of rounding for safety and quality, I like to create subgroups like generic rounding and targeted rounding. Generic rounding is non-specific engagements with staff looking for opportunities and gaps. It's kind of mostly what we do for most of our mock surveys, although we have done targeted ones. So this is kind of like we're going fishing. We're just walking through, we're kind of taking a look around. I may go to your med room and kind of see what I see in there. We'll go over to your supply room and look at for some stuff. For targeted roundings, we're using things like event data to identify trends and significant vulnerabilities. Again, that could be like your falls, sterile processing, fire prevention. Maybe we've had an issue, a serious safety event in our location. We're going to look at a specific thing. It could be something that's come from literature. Maybe we've heard a greater focus by CMS on a particular thing regarding dialysis. So we're going to go straight in and look at that. But bottom line, you want to use the criteria from your root cause to evaluate your current practice. Where are we seeing other opportunities? And here's some kind of the rounding techniques that we look at how people do. And we'll talk about those now. So for safety rounding, now CMS basically says that the condition of the physical plant and the overall hospital environment must be developed and maintained in such a manner that the safety and well-being of staff, of patients are assured. And this is really what comes to the heart of safety rounding. We're looking for vulnerabilities and we're looking for things that threaten the safety of our staff and our patients. And they can be large and they can be smaller. And the slide in the upper right is one that I found when I was at one particular location. They were using their stairwell as a storage facility, which is a big no-no. And these can be complex to simple. So for safety rounds, it could be that facilities team that's going out and we're rounding on their ability to safely manage their generator. Let me see how you're doing that. What type of testing you're doing. We're going into the overhead and looking at wires on sprinkler lines. We're looking at your HVAC system, but it also can be very simple. A lot of places have environment of care rounding documents that a lot of managers will do in their own work centers, and they'll go around and look for stained ceiling tiles and things like that. So you can do this pretty complex, but you can also make it fairly simple. And depending on your staff members, you can train them to do either one. It's a great way to kind of go out and see, do we have any immediate needs right now for safety? Now, we talked the question earlier about engaging with staff members, how important that is. There are some generic safety rounding questions that you want to ask. And a lot of these are geared toward, well, what type of safety event have we had in the past? Have we had anything right now that you're concerned about? Is there something we can do to prevent the next adverse event? And I think these are great questions to ask staff when you're out there to help you identify, are we seeing concerns from our staff regarding culture safety? And there are other ones that you can add to them. I think I pulled this one from an AHRQ reference. But those are some of the questions you want to ask staff as you're going out. And you can make them more specific depending on what type of process that you're looking at. If you're looking at fire prevention, obviously you're going to go through what we do in case of a fire. Talk to me about how you would shut off would you shut off a med gas supply line? When would you do that? How would you evacuate? Where would you go? So as you're developing your tools for your rounding, you want to have some of those questions on a card or something like that that you can pull out and ask your staff to help identify what other opportunities we may have out there. With targeted safety rounds, we talked again about looking at specific trends and vulnerabilities with sterile processing, fire prevention, new procedures. It's heavily focused on observation. So we're out there actually looking at stuff and people are demonstrating their practices. Again, you want to make certain you're using checklists. Make sure you identify your policy, your procedures and processes, and use those as the basis for those checklists as we're going out and evaluating our practice. What example, sterile instrument reprocessing, you're looking at transport of the contaminated instrument, the debridement process, how we use chemicals, we're using proper PPE, what type of documentation we're doing. Our sterilizers and water management is another big one. And how are we storing our instruments, and what's that, are we following humidity and temperature regulations? So those are some of the like soup the nuts that you would be looking at as you're doing those type of targeted safety rounds. For ligature risks, suicide risks, that's another thing you want to look at. Your ligatures, what presence do we have those? What safety risks are in the environment? Contraband, elopement risk, and your one-on-one monitoring process. So this is a high risk type of thing you're going to be looking at, and there are resources out there that you can pull, that you can follow through as you're doing your rounding for that. But I think this is a big opportunity in a lot of the surveys that we do. I don't think organizations are really looking at this as tight as they could be, and specifically going out there and actually watching a process in place. So that's another targeted round. Fire prevention is another one, and I took that picture out at a hospital in California. There's a lot going on there. Everybody's parked their stuff in front of the door, as well as a fire extinguisher with a big no parking sign on it. So asking your staff about your fire response, looking for blocked egresses, and looking at sprinkler heads. Are they covered with dirt and debris? Are we doing fire drills? What do those look like? And are your stairwells clear? And how do we store our chemicals? Is that being done safe? So you can build these targeted safety rounding tools to address these type of specific areas. And there are resources out there that you can use as sources for your checklist as you're building those. Some key tips: ensure your staff are trained on using those checklists. What are they looking for? Integrate that your clinical staff in rounds as surveyors and in your questions to help support an understanding of how the environment affects clinical care. And I think those are some key things when it comes to safety. Unfortunately, when I've been doing some of my safety questions during my survey rounds, I found a lot of people are struggling with understanding fire response. They're not really sure about how to respond in the event of a fire. And I would encourage you to make sure you're focusing on that, because we got a lot of people out there that don't understand the basic concepts of race and pass. I mean, I was brought up on that, and there are a lot of people that organizations still use those acronyms, but a lot of your staff are just not getting it. Let's talk real quick about rounding on quality. So again, rounding on quality, as we mentioned, is looking at the degree of excellence measured against an established benchmark. So how are we doing with our falls prevention efforts based on our established threshold? Are we observing units that are struggling? Why are they struggling? Do we see trends across the organization for falls? Are we seeing drivers for these trends? What can we do to affect positive change? And these would be part of the questions as leaders you'd want to know as you're conducting those quality rounds. These will focus heavily on our quality initiatives and any performance improvement projects that are underway to support efficiency and safe patient care. This will involve engaging with clinical staff on their involvement with quality projects and initiatives to ensure that they can articulate what their work center is working on to improve quality and their role in that project. It is absolutely certain that surveyors will be asking about quality improvement with your staff and will use their observations during subsequent leadership discussions. During our mock surveys, we've asked staff about quality improvement and have received a wide spectrum of responses, from detailed actions and metrics, and they have these quality boards, to people not even understanding if there are any quality initiatives in place. And it's imperative as you're doing your rounding, you're looking at these things and making certain that those are being followed up on. Some quality rounding questions, again, like with the safety rounding, this is kind of geared toward quality and your quality initiatives. And you can use some of these as you're going out and evaluating those things in terms of how do we address quality at our organization. And I've used these quite a bit when I go out and I do my surveys. Some key points, use of quality boards. If you guys have quality boards or storyboards, making certain that people are using them and they know how to speak to their quality process. Know the required quality measures governed by CMS and your accrediting organ and the accrediting organization. What are the requirements for that? Ensure staff can speak to them. Maintain your data on display boards and graphs. Make certain that those are current, and be aware of system-based quality initiatives. Does it reflect your specific facility or unit needs? When I go to NICU and we're talking about falls, now there are baby drops, unfortunately, and you can look at those, but are we looking at things like your donor milk program, which can be risky? Are we even considering that as a potential risk? Or CLABSI or things like that. So make certain that your quality initiatives are reflective of that organization or that unit that you're looking at. Those are some key points there. Any questions so far? We're getting into our home stretch here.
No, sir, we had to have someone log off, but you're doing great.
Okay, so let's put it all together. This picture here was an interesting one. We just started a mock survey and an ED. And that's usually what I do the first morning wherever I'm at. People, I think, were still sleepy. Opened up a cabinet drawer and I found that nice green bag of stuff in there. And I asked my escort, so is this where you keep your big bag of weed? And their eyes got really big. And when we pulled it out, which you can't really see on the picture, somebody had handwritten in there, vomit control, do not smoke. So again, as you're rounding, you need to get in places because you never know what you're going to find. It was really kind of funny when we saw that everybody calmed down and realized it wasn't what we thought it was, but you never know. So rounding data. So if we were smart and we have set up our rounding program to where we have good tools, we're pulling in data. So what do we do with it now? We have to aggregate and analyze what we're finding. Are we seeing trends? Are we seeing opportunities? And what do we need to work on right now? Or is it something that we can use later? It's important that you use data to help drive change. And the other part about data that's not on here, data gets communicated up to your leadership. So are we taking that time and that opportunity to bring data to our leaders and saying, hey, you remember when you said that you weren't certain about how rounding is really going to help? Well, this is some data that we're finding out there, and here's some serious opportunities that we need to address. If we don't get this fixed, we're going to have an issue. And data, really, where it comes down to is important. That's really what you show. Build your analysis process and your reporting structure before you're rounding, because you don't want to think about that as an afterthought. What are we going to measure? How are we going to analyze it? How are we going to report that out? You may need to modify the data that you're pulling. You won't know that if you wait till after you've actually done your rounding. Don't forget about data reliability. Are rounds self-reporting? And I'll give you an example. I was at a place in the Midwest and they showed me their hand hygiene dashboard. It's a beautiful big board. All the places were reporting what their data was, what their hand hygiene was. And everybody was 95, 96, 98, 99, 100, a lot of 100%. And I got to pre-op holding, 34%, 54%, 63%, 45%. And I said, what happened with pre-op holding? Well, we're really working on that. And I'm like, no. I believe their data. I necessarily don't know if I believe everybody else's. And that's when I asked the question, is this self-reporting or is this secret shop? Or are you guys going out and looking at, well, these are self-reporting. I'm like, you need to give that manager an award because they were being honest in their rounding data. We need to pull our rounding data apart and conduct comprehensive review and discussion and avoid those quick conclusions. Are we looking at contributing factors and risks that may affect the data? Have we even considered things such as health equity as a contributing factor? Are we seeing disparities in our data between different unrepresented groups? Are we seeing different types of patients that when we're doing a rounding that we're seeing different type of results? If we are, we need to go back and look at that. Maybe we need to separate our data out and make certain we're comparing apples to apples and oranges to oranges. Look for positive practices, models for others to emulate. Again, that's one thing we need to do. And then once you go out and you're pulling all that data and looking at best practices, you look at opportunities, you get to repeat it and do it all over again. That's the whole thing about rounding. Outcome measures, let's talk about those. We'll talk about outcome process measures. That's part of the data. So outcome measures may seem to represent the gold standard in measuring quality or compliance, but an outcome measure is the result of numerous factors, including many beyond the provider's controls. Some would even argue the purpose of measuring the aspects of healthcare is to improve patient outcomes, whether it means reducing utilization or adverse events, less infections, less complications, less deaths. So when it comes to promoting the use of outcome measures, proponents usually note that outcomes are really what matters to patients and represent the most important aspects of care, namely the resulting health of those treated. And those measures often reflect the biggest financial implications and therefore allow for a more straightforward calculation of saved costs and increased value. However, we need to consider process measures because process measures drive outcome measures, and you can improve on your process measures a lot quicker than you can with your outcome measures. So as you're doing your rounding and you're looking at your data, make certain you're able to discern between what type of outcome measures are you looking at and what type of process measures that you're considering. Process measures often reflect or intend to promote evidence-based best practices that have been proven to help improve outcomes or patient safety. Process measures usually, again, are directly measurable and immediately available. That makes them more trackable and easily targeted in a quality improvement intervention. When people talk about the drawbacks of process measures, they usually say something like the fact that it can be difficult to demonstrate a direct correlation between improvements and a process measure performance and a corresponding improvement in patient outcomes. So we went out and we did a rounding on our falls risk bundle process. Are we following that? So okay, well, we made some interventions. Did we see improvement in the outcomes or not? You may or may not. Again, it depends. Depending on what we're looking at, and it depends on the events that happen, can they tie directly back into those interventions that you made? So as you're doing your rounding, looking at process measures, just have some of those considerations. They also talk about some surveillance bias. So again, I think a lot of that, when somebody knows that they're being watched, you get the Hawthorne effect and people are going to probably, hopefully, do the right thing. So you have to think about that as you're looking at processes. And some of this may even be just discussion with people, because sometimes people will be quick to trip themselves up when you're actually talking to them rather than when they know they're being observed. Again, some of the next steps when you're looking at getting all your data, you want to analyze, integrate it into a quality and safety reporting process. This is often missed by a lot of people that are getting rounding data. I think they're struggling with actually getting what we're looking at into a form that can be displayed and presented to your leadership. Looking for trends. I can't say enough about run charts and things like that. I'll ask for somebody, well, tell me about your rounding data. Are you looking at your falls bundle compliance? Well, here's where we're at right now. Okay, well, where have we been? And what interventions have you made? And so make certain that you're being robust in how you're displaying your data from rounding. And when you make those interventions, be able to demonstrate on either run chart or on your dashboard where you've made some changes, and is there a potential that we've seen a correlating improvement or maybe even a degrading in our compliance rating, and why did that happen? And I can't emphasize enough, you got to elevate your rounding data to your leadership to show them this is what we've been seeing out here, this is where our concerns, and this is where we need your assistance to improve. So rounding measures of success. How do we know that that our rounding is helping. We talked about it earlier, response to culture safety survey of frontline workers and managers, that, yeah, my leadership is showing up and they're engaged and they're, I can report things to them. The number of near miss errors reported per month from voluntary reporting systems. So as you're going out and you're promoting reporting of errors and talking to your team about culture safety, and it's important to report real events, but we also want to report the actual events and the near events. So that way you can take a look at those numbers to see how those move. The number of safety-based changes made by managers per year. So as we're going out and doing a rounding, are we seeing an increased number of safety-based changes on processes? That tells us that we're actually seeing a more increased focus on safety and reliability. And percent of changes in overall surveillance data. So such as your infection rates. And again, those outcome type measures may be a little bit drawn out and getting reported. So finally, I appreciate your time. Once you get done with rounding, your first set of rounding, you have to go back and do it all over again. And as Yogi said, it's like deja vu all over again, because sometimes you will find the same thing everywhere, every time you go out. It's just a matter of just keep plugging at it, keep going, and affecting change. Does anybody have any questions?
Well, I've got one in the pocket, and it's Kendall from Iowa. She wonders when you're going to present again.
I will be presenting, I think it's the 1st of September. We're going to talk about successful regulatory programs. Which ones we've seen out there and what are those elements. And I'm also going to be presenting at the CIHQ conference in October. I'll be presenting on the, well, they call it the recent changes from CMS on quality and specifically performance improvement, but they actually are probably a year or two out. So I'll be talking about performance improvement, what CMS expects you to do, and what are some things you can do to get there. So.
Yes, we're really looking forward to that, Chris. Thank you. It'll be Omaha East, they call it. So it's just over the bridge from Omaha and Council Bluffs, Iowa, early October. And that information is on the CIHQ website. Someone wonders if they're able to get a link to this recording. Yes, it will be posted on the CIHQ Partner YouTube channel within a couple of days. I'll try and get to it this afternoon, time permitting. Well done, Chris. You got, oh, you're very welcome. You're very welcome. You got a request to maintain. Anything else? All right. If there's nothing else, perfect timing. Right. Carlton Bennett, thank you for the information. Just retired from the Navy after 38 years myself. Thank you so very much for your service.
All right. Hoorah.
All right, everyone. Enjoy your afternoon. And yes, I agree, Christine. Thank you. And have a great afternoon. And I will get this posted as soon as I'm able. Thank you again, sir.
Thanks, y'all. Y'all have a great day.
See you in October.
Yes, ma'am.